So there is a big difference between treating the general population and elite athletes. First of all, it creates quite a challenge because there's enormous pressure on getting these people back to the same level of activity they had before they were injured, and to do so at top speed, so as quick as possible. So I quite enjoy the challenge of dealing with them because it really tests me. But there's been a huge benefit to me. It's a tremendous discipline because I have to perform. And by improving my treatment, my judgment, my surgery and the post-operative rehabilitation, it does really help my general population patients. So there's a really good knock-on from treating this group. And if you think about it, if we didn't have the pressure to treat elite athletes, the quality of treatment available to the general population wouldn't be as good as it is. For example, say with anterior cruciate ligament surgery, it's come on hugely and it's driven by the need to get athletes back to the top. If it wasn't for professional athletes, we wouldn't have ACL surgery at the level it is now. And so they've driven quality, they've asked the questions of surgeons and doctors to improve treatment. And so the whole population really benefits from this rather elitist practice. Elite athletes are a different group and they are very instructive for me. They get rare things, which means that when I see that in a member of the general population, I don't miss it. We've studied certain injury to the medial collateral ligament, for example, which only seems to occur in footballers. And many a patient from the general population would come to me having had months or even years of pain, and no one's been able to work out what it is. But because I treat elite athletes, I see it much more commonly than other surgeons. In fact, we've been able to put a series together and published on it. And it's a very unusual thing. So that's a great lesson learned from athletes. But the other thing is that they get ordinary problems, but they're exaggerated tremendously. And I'll give you an example for it. We see people with meniscal tears fairly frequently. And if you treat the general population, it'd be very easy not to realize there's a difference between a medial meniscal tear on the inner side of the knee against a lateral meniscal tear on the outside of the knee. They are chalk and cheese. And if you deal with athletes, removing meniscus on the inner side of the knee has fairly little consequence in the short to mid-term. When they're in the middle age or old age, they might get some arthritis. But to remove any meniscus on the outside of the knee, the lateral meniscus, it's really the beginning of the end of that athlete's knee. And the most common reason I will retire a player from football or rugby, for example, is following the consequences in terms of arthritis of having some of that meniscus removed. And so I've learned that at all costs we must try and preserve the lateral meniscus with repairing it rather than removing it if it's possible.